Hey everyone, welcome back to Nurse Crit. My name is Chasen. I'm an acute care nurse practitioner. Don't you just love it when you're busy nursing and you get a phone call from lab? Hi, I'm calling to report a critical lab. Your patient's potassium is 7.4. What is your name? Thank you, good luck. So, do you know what to do when your patient is hyperkalemic? You will by the end of this video. The answer is right on the title screen, so stick around to the very end for a full explanation. Here are the learning objectives. In this video, we will define hyperkalemia and why it's bad, understand the degrees of hyperkalemia, review signs, symptoms, and risk factors, identify associated ECG changes, and lastly, we will discuss the medical management of hyperkalemia. What is hyperkalemia? Potassium, abbreviated as K on the periodic table, is a mineral that serves as an electrolyte within the body. Around 98% of the total body potassium is found in the intracellular space or within the cells. Just a small amount is maintained within the blood plasma, around 3.5 to 5 milliequivalents per liter. When the plasma levels rise above 5 MEQs per liter, this is known as hyperkalemia. So what's the big deal? Well, potassium plays a critical role in nerve and muscle function. Your heart, which is a muscle with nerves, can be adversely affected when potassium levels get too high. The electrical activity of the heart gets disrupted and dysrhythmias start to develop. If the hyperkalemia is severe enough, it will lead to ventricular fibrillation, cardiac arrest, and death. Kind of a big deal. For those who may be unfamiliar with the dangers of potassium, just know that death row inmates who undergo lethal injection, potassium has traditionally been one of the medications used. It's very good at stopping the heart from beating. Not all sources agree, but hyperkalemia is usually considered mild when the serum potassium is 5 to 6 MEQs per liter. 6.1 to 7 milliequivalents is moderate hyperkalemia, and greater than 7 MEQs is severe hyper-K. But this is a bit of a dangerous paradigm. It seems intuitive that mild hyper-K would be less dangerous than severe hyper-K. However, that's not always the case. Sometimes patients with severe hyper-K never have a single sign or symptom and do completely fine. And conversely, a patient can go into cardiac arrest from only a mild hyper-K. There are many variables that affect how sensitive someone is and how they will react to hyperkalemia. Therefore, you should basically treat all degrees of hyperkalemia as a serious medical emergency. The signs and symptoms of hyperkalemia are rather non-specific and therefore not very reliable. Patients may experience muscle weakness, fatigue, dyspnea, palpitations, chest pain, nausea, vomiting, or paresthesias. Or they may just be asymptomatic. One of the earliest cues that a patient is hyperkalemic prior to lab testing may be found on the ECG. The first notable change is usually tall peaked T waves with a narrow base, best seen in the precordial or V leads. There may also be a short QT interval and ST segment depression. As the K levels continue to rise, everything starts to widen. Imagine the ECG tracing as a string and someone is pulling the end and straightening it out. You'll start to see a prolonged PR interval, diminishing P waves, and a widening of the QRS complex. As everything gets wider and wider, you end up with a sine wave appearing ECG, which eventually turns into ventricular fibrillation or asystole. ECG changes are not very sensitive for hyper-K, but when they are present, it should prompt an emergency response regardless of the actual potassium level. In other words, even if the K is mild at 5.5, if there's already ECG changes, that is bad and you need to treat it immediately. Don't let OK numbers falsely reassure you when you're already having clinical changes. Obviously, the most definitive way to identify hyperkalemia is by a blood test. A routine chemistry panel is generally how we diagnose it, but there are certain patients who have much higher risk for developing hyper-K. Almost all hyperkalemia occurs in patients with some degree of kidney dysfunction. A normal functioning kidney is really good at regulating potassium levels. Hyperkalemia is mostly found in patients with an acute kidney injury or more so in those with end-stage renal disease. The other most common cause of hyperkalemia is medication use. There are many different medications that can alter potassium excretion in the kidney. Potassium-sparing diuretics, NSAIDs, ACE inhibitors, ARBs, direct renin inhibitors, beta blockers, heparin, succinylcholine, Bactrim, immunosuppressants like cyclosporine or tacrolimus, and the oral contraceptive drospirenone. Any of these drugs in isolation can cause hyperkalemia, so any combination of them really increases the risk. In addition to kidney failure and medications, there are other less common conditions that have a strong predilection for developing hyperkalemia. In other words, the condition itself is not that common, but when present is likely to cause hyper-K. One of these rare kidney diseases is called type 4 renal tubular acidosis. This is a condition in which there is an aldosterone deficiency or resistance to it. You may recall the function of aldosterone is sodium retention and potassium excretion, so a deficiency will cause the kidneys to hold onto potassium. Another, less common condition that strongly predisposes patients to hyper-K is a ureteral diversion or ileal conduit. In patients with bladder removal, usually from cancer, the ureters are surgically connected to a piece of small intestine which is directed out the abdominal wall as a urostomy. Because the intestinal portion still retains its absorptive abilities, patients can unwantedly reabsorb the potassium that the kidneys were trying to get rid of. Complete urinary obstruction, primarily from BPH, is another notable cause of hyper-K. Sometimes inserting a Foley and allowing urine to flow normally is all that is needed to fix everything. All the risk factors listed thus far involve decreased excretion or increased reabsorption of potassium, but there are a few more conditions in which there is a transcellular shift of potassium. The high levels of potassium that are normally hiding within the cells make their way out of the cells and into the blood. Cellular destruction from rhabdomyolysis, tumor lysis syndrome, hemolysis, and severe burns can release significant amounts of potassium. And the last significant cause of this transcellular shifting is metabolic acidosis, which we do see quite often. Now onto the most important part of the video, how to treat hyperkalemia. The definitive treatment for life-threatening hyper-K is dialysis. This is the most effective way to clear excess K from the body. However, if this is not an existing dialysis patient with vascular access, it can take a significant amount of time to insert a temporary dialysis catheter and arrange for hemodialysis if there is not in-hospital dialysis staff. So in the meantime, or for less severe hyperkalemia not requiring dialysis, there are multiple emergency medications we can use to stabilize or treat the patient. Do I got any size queens out there in the audience? Because this mnemonic is for you. For patients requiring emergency medications for their hyperkalemia, remember you need to see a big dick. Conveniently, this acronym even groups the meds by mechanism. We use meds that stabilize, shift, and or eliminate. The first letter is C, which stands for calcium. Calcium does not in itself lower potassium levels. It is used to stabilize the cardiac membrane potential, which reduces dysrhythmias. It's just a protective measure. Calcium is usually not indicated when the ECG only has peaked T waves, but it should be used if you note any of the intervals widening. Calcium gluconate should be your initial choice over calcium chloride because gluconate is much safer to administer peripherally. Also, calcium chloride can theoretically worsen an acidosis, which is one of the causes of hyper-K mentioned earlier. Therefore, aim to use calcium gluconate unless the patient is already coding, in which case an amp of calcium chloride can usually be administered more rapidly. The next class of medications are those that cause a transcellular shift of potassium back into the cells. Earlier we discussed diseases that cause the K to leak out. Thankfully, we have drugs that can force the K back in. But understand that these are all temporary fixes. The potassium will eventually start to leak back out as the meds wear off. Albuterol, Yes, the stuff that we use to treat asthma or COPD is a beta 2 agonist and can drive K back into hiding. You administer it the same way as any nebulizer, but the only difference is in the dose. For hyper K, you need to use 20 milligrams rather than the 2.5 you're used to seeing. Admittedly, this is the intervention I see the least of, but it's still a good tool to have in your back pocket. B is for bicarb. This one is a bit more controversial. We know acidosis leads to hyper K, and conversely, alkalosis leads to hypo K. But sodium bicarb amps can paradoxically worsen hyper K by something called solute drag. Amps of bicarb are so concentrated, they increase the serum osmolality and can draw K out of the cells. The ideal way to give bicarb is as a drip. Mix 3 amps of bicarb in a liter of D5W and you have an isotonic bicarb drip. But if your patient is not actually acidemic, bicarb may not be an ideal choice. It's always an option, but be selective in who it's used on. Creating a metabolic alkalosis has a host of negative consequences on the body, including lowering ionized calcium levels, which is counterproductive to what we just gave 2 letters ago. I and G stands for insulin and glucose. These two always go together. Insulin is another medication that forces K back into the cells. We give 5 to 10 units of regular insulin, IV push, not subcutaneously. We co-administer glucose, or D50, simply to prevent hypoglycemia from the insulin. If the patient's blood glucose is already super high, like 300 or 400, you might not even need to give additional glucose with the insulin. In fact, severe hyperglycemia can also worsen hyper K by the same solute drag mechanism as bicarb. So don't give extra glucose if it isn't needed. If you administer IV insulin, be sure to check finger sticks every 30 minutes for a few hours after. Once you're confident you aren't headed toward hypoglycemia, you can space out the finger sticks back to your Q4 or Q6 hour routine. The last group of meds are those that promote the elimination of K from the body. These are a definitive way to lower the potassium. Sometimes these meds are sufficient to avoid hemodialysis altogether. D is for diuretics. With the exception of end-stage renal disease patients, this is a great treatment strategy for any patient who can still produce urine. You give high doses of loop diuretics, or even a continuous drip, to pee off all the extra K. To prevent dehydration and hypovolemia, you should co-administer IV fluids with the diuretic. Fluid selection is quite nuanced. Normal saline has traditionally been used, but newer studies recommend using lactated ringers instead. Despite LR having a small amount of potassium in it, it isn't enough to significantly raise the serum levels. And interestingly, NS is actually the one that can worsen hyper K by creating a hyperchloremic acidosis. A reasonable third option for fluid replacement is the isotonic bicarb drip mentioned earlier. But since context always matters, use what is most appropriate for the situation in front of you. The last letter is K, which stands for K-exhalate. In patients that cannot produce urine, GI elimination is your only remaining choice for meds. K-exhalate is an old drug, but every hospital has access to it. It's a cation exchange resin that forces potassium out into the poop. If you have access to newer cation exchange resins like Lokelma, that is generally preferred. But obviously, that would ruin my wonderful mnemonic. And that is how you treat hyperkalemia. You must remember to see a big dick. If you feel like I talk for too long, a 1-minute summary of this video can be found on my Instagram page. If you found this video helpful, please like and share it with your coworkers, and consider subscribing to my channel so you don't miss out on future videos. Thanks for watching and see you next time.